Thank you, Dr. Rohit. Now we move on to our next session, which is the session on ALK mutated lung cancers, and we have 5 talks in this session. We'll start off with our first talk, which is interpretation of ALK testing. So I would like to invite Dr. P Shrivastava, who is a medical oncologist from Kokilaben Ambani Hospital in Indore. Sir could not make it today because of some flight-related issues, and he will be presenting his talk virtually. So over to you, sir.
The opportunity. Unfortunately, because of flight cancellation, I could not make it. So today my talk is on interpretation of ALK. As we know that we are moving towards the treatment which is based on molecular studies or some mutations. So that is very important. We know very much about the EGFR, but ALK is still creating some issues with that. But we have many of the drugs available having response going towards the overall survival benefit. So today we are going to discuss something about ALK. So next slide, please. So it is the history of ALK. It was first cloned in 1994 when NPM1 ALK fusion protein was identified in anaplastic large cell lymphoma, and on the name of this, it got the name of ALK. It is a protein which is a member of insulin receptor superfamily of receptor tyrosine kinases. Physiologically, it is expressed only in the brain and spinal cord of the embryos. It is essential for neurological development, and in adulthood, it is constitutively expressed in the limited nervous tissue. So mainly it is expressed in brain, spinal cord or nervous tissue, not anywhere else. It resides on a short arm of the chromosome 2, which constructed mainly of 2 large introns and 26 exons. And this is the illustration of that paper published in 1994. She's showing this, the discovery of ALK in ALCL case. Next slide, please. So if we see this, just go back one slide. Yeah. So how the structure of this ALK is, it is constitutive of N-terminal extracellular domain with a single pass transmembrane region and intracellular kinase domain. And molecular pathogenesis of ALK begins with the chromosomal rearrangement that partner the 3 coding sequence of intracellular signaling domain and 5 promoter element and coding sequence of the other gene. So molecular pathogenesis like ALK rearrangement or ALK fusion, it happens intracellularly. ALK activated when ALK ligand binds to its extracellular domain, resulting in dimerization and autophosphorylation and activation of well-known downstream signaling pathways, which cause the help in the cell proliferation, survival, and differentiation, cause the tumor progression. Next slide, please. So ALK, it amount around 3 to 7% in all NSCLC cases and around 20% or 12% of all lung adenocarcinoma, although it's very less percentage. But nowadays, as the availability of broad panel NGS, as we are going in all cases of advanced lung cancers, we may find this number or percentage will rise in some time or some next future. It is associated with more aggressive histological grade, usually found in younger females and patients with limited smoking history or particularly non-smokers. And on ethnicity wise, it is the incidence is similar everywhere. And as of recommendation to go for ALK assessment in all cases of advanced non-squamous NSCLC cases, technique may be ISC or FISH. Next slide. So this is the depiction of EML ALK fusion, which is the main culprit for development of malignancy. Here we can see first description of EML ALK4, it found in Japanese male smoker person in 2007, where it was a result of inversion in chromosome 2p, result in the fusion of N-terminal portion of EML4 with kinase domain of ALK. So here is a depiction. We can see how it rearrangement happened, and we may found the various variant of ALK. It may be V1 to V8 or V9. Next slide. Next slide, please. So it is the depiction of various variants of EML ALK fusion. We can see this variant 1 to 9 is there. The most common one is the EML ALK fusion, followed by the variant of 1 is most common, and followed by third and second. EM ALK can fuse with other also, like KI5, KI5B, HIP1 and KLC-C1. So as of now, there is no significance of these other fusions. We have only the significance of EML ALK fusion for in clinical practice. Next slide. So where come evidence came for the EML for ALK positive lung cancer? How it was it suggested that it is a malignant fusion. So it came out from the study which was done in 2008 in mice, where they have infused EML4 ALK fusion gene in the mouse, and they found that almost all 100% of EML ALK4 ALK transgenic mice developed lung adenocarcinoma, and even followed by later on they have tried the TKIs, because cresotinib was available at that time. They have found that the mouse were responded who developed the adenocarcinoma because of this fusion gene insertion. Next slide, please. So apart from lung cancer, ALK or lung cancer fusion gene rearrangement, ALK can be found in various malignancy in the form of fusion, in the form of overexpression, or in the form of point mutation. So it is a quite long list of like we can see ALK overexpression can be found in melanoma, lung cancer, neuroblastoma, GBM, rhabdomyosarcoma, ovarian cancer, breast cancer, astrocytomas, Ewing sarcomas, and retinoblastomas, and point mutation in thyroid malignancies, inflammatory fibromatosis, and neuroblastoma. Then the fusion, which is very important as of now, it is usually in the lung, colon, ALCL, IMT, and DLBCL. Next slide, please. Next slide. So now how we can diagnose this ALK rearrangement? Here is a depiction which can be shown. Here we can see this is the wild type normal ALK EML4, and now it is a fusion which is called rearrangement fusion. So we can diagnose the ALK with the three techniques: PCR, ISC, and FISH. So by ISC we may found the ALK protein. By PCR it can be used for mRNA product, and FISH or PCR can be found for the ALK fusion gene rearrangement. Next slide, please. So this is a recommendation from NCCN 2024. These are the treatment methodology for assessment of ALK. First, I can say this ISC, which has been approved by FDA, single standalone testing. If it is positive, then it is not required to confirm by FISH. We may use FISH break apart probe. We can use numerous NGS platforms nowadays. As I can say that we are using NGS broad panel in all of our patients, and another one is the treatment real-time PCR. So these are the various treatment methodologies for ALK which are recommended, but nowadays we are following the broad panel NGS. Next slide, please. So this is the depiction of what percentage of ALK fusion may found in early as well as metastatic lung cancer. If we see in the early, it is a 0.8% only. In the metastatic, it is a 4.4%. Quite significant positivity rate is there. And as I earlier said, because of the availability of NGS, it may increase in future. Yes. Next slide, please. So how this signaling starts, as we have already discussed, this ALK signals this extracellular domain attached with the normal ligand, then phosphorylation happen and downstream pathways activated. This is kind of a normal, but oncogenic ALK signaling, it happens intracellularly when the N-terminal binding partner of the ALK bound to the C-terminal ALK tyrosine kinase, and it start proliferation and tumorigenesis. So these are the various inhibitors which can be used. Already discussed about the variants, like V1 is the commonest one, V3 followed by 2. Yeah, next slide, please. So this is again the similar depiction of how this downstream pathway has been activated. Next slide, please. So it is some points about the ALK positive non-small cell carcinoma. It is more likely to have a metastatic disease in pericardium, pleura, and liver. More likely to brain metastasis, but is advanced. Advanced setting, 25% of patients upfront diagnosed with brain metastasis, and later on, if they progress, 45% is the possibility of the brain mets if we are not using non-penetrating non-penetrating brain barrier targeted therapies. Worsening outcomes in advanced setting. In the pre-targeted therapy era, there was a very less survival in ALK positive lung cancers, and impact of chemotherapy is modest in these settings, seems to be more sensitive to pemetrexed based regimen with respect to ALK negative NSCLC, which may be due to fact that ALK positive adenocarcinoma has a lowest level of thymidylate synthetase. Next slide, please. So this is a depiction where we can see the response or overall survival response rate in ALK positive who has been treated with TKIs, ALK positive which were control, and wild type. So clearly there is a significant changes, or you can see this line is graph are well separated for ALK positive who has been treated with TKI, that was the crizotinib. Next slide, please. And there are some mechanism of ALK independent resistance, bypass pathway activation, histologic transformation, challenges of polyclonal resistance. These are different mechanisms. I will not go into the detail because the presentation is due. Next slide, please.
Sir, sorry to interrupt, but I think the time is up, so we request you to conclude.
Slide, please. So, ALK as a therapy, we can see the field of ALK positive NSCLC have transformed by development of successive generation of selective TKIs, which are potent and brain penetrant. Next slide, please. So this is a list of recent FDA approved drugs which are there: crizotinib, alectinib, brigatinib, lorlatinib, and anasertinib. Next slide, please. This is a recommendation from the NCCN as of now 2024 updated, where we can see the broad panel NGS. Please continue my slides. Next. This is the strongly recommendation for broad panel testing, including ALK, and nowadays the recommendation for biopsy plus plasma cells testing together to get a better and early responses. And concurrent testing can improve time or test. If clinically actionable marker is found in one study, then we can start our treatment on the basis of that. Next slide, please. So treatment is guided by available result, and if unknown, the patient can be treated with without driver oncogene mutation. Next slide, that would be my last slide. So this is again the recommendation from NCCN, that is in ALK rearrangement cases, upfront diagnosed, we can start in any of this TKI, alectinib, brigatinib, lorlatinib, ceritinib, and crizotinib in some circumstances. And if it's found after the starting of treatment, we may start for TKIs, or we can wait after the completion of our chemotherapy, whatever is going on. Next slide, please. Yeah, thank you so much from my side. If any question, I'll be happy to take that question.
Thank you.
Good afternoon.